Oral cancer is one amongst the top 3 cancers in India. Despite its high prevalence, seeking treatment for this condition is usually a delayed one. One of the topmost reasons being myths around oral cancer. I am Chetna Belgire in conversation with Dr. Narayana Subramaniam, head and neck surgical oncologist from Bangalore. Welcome to South First, sir.
Thank you so much. Thanks for having me.
So could you first tell us which parts of our mouth are prone to oral cancer?
So typically oral cancer can affect any part of the mouth, right? It can affect the tongue. It can affect the inner lining of the cheek. It can affect the upper or the lower jaw bones. It can affect what's called the floor of the mouth, which is under the tongue, and it can affect the lips. So virtually any part can be affected by oral cancer.
Okay. So what is the incidence in India, especially if you could tell us about South India? I mean, what is the prevalence like?
So oral cancer is one of the commonest cancers in India. More than 200,000 new cases every year. So India is considered the oral cancer capital of the world. It's all over the country. The reason is tobacco prevalence. 1 in 3 adults use tobacco, but a significant portion of patients also don't use tobacco.
Okay.
The incidence seems to be increasing, even though the incidence of tobacco usage is reducing. Still, the incidence of oral cancer seems to be increasing.
Okay. So that brings me to the point that, there is a general first myth saying that, because there is tobacco, then there is smoking, and then alcohol. Then there are many, many women, many men themselves who don't do all of these, but then they believe that how can I, be somebody who's susceptible to oral cancer? So let's start bursting these kind of myths one by one. If you could go by each of it, we could start with any of it which you think is the most commonest believed thing when it comes to oral cancer.
Absolutely. So I think maybe we can start off first with the symptoms, because many of us have a very stereotypical idea of what oral cancer looks like. And the reason for that is, the portrayal in movie theaters and other public places, the smoking cessation ads. So typically what we imagine is that oral cancer is a huge, deformed cheek with an ulcer and a big wound on the face, but very often it's innocuous, right? Okay. So when you want to pick it up early, you have to be aware of the symptoms. So one thing is you can have an ulcer or a non-healing kind of wound anywhere in the mouth. It can be on the lips, cheek, jawbone. Sometimes it can present as white or red patches that don't go away when you rub them. Any of these that last for more than 2 weeks can be a sign of oral cancer, need to be checked out. Sometimes you can have lumps and bumps in the tongue, on the jawbone, on the hard palate. Sometimes you can have difficulty opening the mouth. You can have swellings in the jawbone. You can have blood-tinged saliva. You can have lumps in the neck. So you can have lymph nodes in the neck typically, which are enlarged. So any of these can be a symptom of oral cancer. Okay. If they're prevalent for more than 2 weeks. So get it checked out. It may not be oral cancer, hopefully, but we absolutely need to rule out oral cancer if you have any of these symptoms for more than 2 weeks.
Is it always painful, sir? Any or all of these symptoms, whichever you mentioned now, is it always painful? Or
No, so many of them are not. So usually they're painful only when they're advanced, which is why patients delay seeking treatment. Other things like toothaches and infections are often very painful. So patients seek treatment immediately, but these are often quite innocuous and they don't create many symptoms. So till they get much bigger and involve larger areas, they're totally painless. So which is why we have to be aware of them and identify the symptoms early.
Okay. So now let's come to the myths around oral cancer. So if we could start off with the most commonest myth that about tobacco usage and smoking.
So tobacco and alcohol use is a very important factor in causing oral cancer, but it's not only tobacco and alcohol users who get oral cancer, right? So for reasons unbeknownst to us, about 10 to 15% of patients have no history of tobacco and alcohol, either smoked or chewed or anything else, areca nut, none of those risk factors also develop oral cancer. Sometimes they have a risk factor that we can identify. You can have chronic trauma from a sharp tooth or an ill-fitting denture. Sometimes you can be slightly higher risk if you have HIV, or if you are on transplant medication, if you had a renal transplant. But 10 to 15%, a lot of them don't have, so which is a sizable portion, as you can imagine, when you have 200,000 new cases every year, don't have any identifiable risk factor. So it's important to realize that if you have any of those symptoms that we listed out, whether or not you use tobacco, you use alcohol, it could be oral cancer, and get it checked out.
Okay, how much role does areca nut? Because especially in South India, in many parts of Karnataka itself, there are people who chew on this. So is that also a risk factor? Has it been proven?
Absolutely. Absolutely, it's proven. There's data that shows that areca nut by itself is a carcinogen. And the problem in India, why we have such a high risk of oral cancer, is because we put multiple carcinogens together. So tobacco independently causes cancer, areca nut independently causes cancer, alcohol also independently causes cancer. So one thing that we realized, I guess, going to the next point, which is age, is that when we looked at data in our country and we looked at data in other countries, so we pooled nearly 5,000 patients from all around the world. For some reason, in Southeast Asia, especially in India, oral cancer appears 10 years earlier. So the
Oh.
average age at which oral cancer appears in the West, which is Australia, Canada, other parts, Caucasian populations primarily, is 65 years of age. So the median age at which patients present with oral cancer is 65. In India, it's 10 years younger. So 55 is the median age. We don't know why exactly this happens. We're still studying it in great detail, but it could be the fact that we are putting multiple carcinogens together, and we could have some genetic predisposition to develop cancer early.
Mm-hmm.
So
So it's
again,
not true that
oral cancer used to be,
sorry.
sorry, please go ahead.
So it's not true that, only people who are above 65 years of age or 70 years of age. So I am very young, so I am not susceptible to oral cancer. That's not true.
Absolutely. So this was the teaching when we started off our training. The stereotypical patient is 65 years and younger. They've been using tobacco and alcohol for 20, 25 years, but that's really not what we are seeing. In the OPD, in the clinic, we're operating patients every day who are, under 55 years of age. So there's nothing to panic about. It's just being aware of the fact that it could be cancer. So the most common cause is squamous cancers, which comes from the lining of the mouth. But younger patients can also have slightly different cancers that arise from the jawbone themselves, or from the muscle in the mouth or the fat in the mouth. Those are sarcomas. So there are different types of cancer. So when you get very young patients, sometimes you get 15 and 20-year-old patients. Those can be the rarer types of cancer that you get in the mouth. So
Okay.
again, nothing to panic at all about. It's just to be aware that when you get any of these symptoms, get it ruled out as a cancer primarily by an oncologist, and then proceed to any sort of treatment if your symptoms have been going on for 2, 3 weeks.
So we discussed on the age, but what about the gender? There is this general belief that only men get oral cancer, or women who are in the rural areas, they tend to get oral cancer. So these are some of the myths. Is that true? What is it like?
Absolutely a prevalent myth. So, funnily enough, when you look at tobacco use in India, men and women both use a lot of tobacco. So, 1 in 3 adult men, 1 in 3 both in urban and rural, use some form of tobacco, either smoked, chewed, or whatever. So, we see plenty of women with oral cancer. Some of them are tobacco related, some are not tobacco related. And for some reason, there's an increasing epidemiological trend of younger women without any tobacco and alcohol increasing incidences of cancer. Again, nothing to panic about. It's just that when we identify these early and treat them, they have an excellent chance of cure. So that's what I really want to drive home. The whole point of this is not to make anybody alarmed or panicky. But when we identify these early, they have excellent cure rates. So we need to pick them up early. We have to have suspicion that it could be a cancer. So when we get treated, you can go on to have nice, long, fruitful lives, nothing to worry about. But we just have to be aware and make that diagnosis early, and that makes all the difference.
So again, I know there is again this myth about, when you look at the treatment option itself, like there is this thing that it can't be cured or it can't be, treatable, and there is going to be a lot of deformity because of that. So how does that go? Because again, like you said, the movie ads show it that way. So what does it?
Correct, correct. So one thing I really want to put on record is that oral cancer is very treatable, right? We have data that we put out from our group, other groups in India, all over the country. We have excellent cure rates. So stage for stage, even advanced oral cancer has better cure rates than many other cancers, better than stomach, better than pancreas, better than the bile duct, multiple cancers. We have excellent cure rates if we identify the extent of disease, stage the patients properly, and treat them properly, which usually means surgery plus or minus radiotherapy, depending on the stage. So, number one, we have to assume that it is very curable, right? It's not that whatever you do, disease comes back. We have a lot of anecdotal information when we have patients. Somebody knows somebody who underwent treatment and died, but every patient is different, right? Every patient is treated different, and the treatment options have exploded, right? The way we treat patients fundamentally has remained the same. But when we look at reconstruction and we look at rehabilitation, we are able to do a lot now in the first setting. So, very often, if we have to remove multiple teeth, we can reconstruct, give the patient a full set of teeth during the same time. So, they wake up from the same cancer surgery with a full set of teeth, no scars on the face, no, deformity, good symmetry between both sides of the face. We are really able to do very complex operations that get the patient back to work, back to life very soon. Unfortunately, this wasn't available 10, 15, 20 years ago. But with the explosion in technology, with the explosion in expertise and technique, we are able to do this even for patients who are not very economically well off. So the cost of all of this has come down considerably. The expertise is really available now. So what I want to again put forward to the public is one of the reasons why patients with oral cancer don't get treatment is they're afraid of terrible deformity and dysfunction, not being able to speak, to appear badly, never appear in public, eat in public. For the vast, vast majority of patients, that's not the case anymore.
Okay.
If you come in early, or even if you come in with an advanced disease, you're treated appropriately, your rehab and reconstruction are planned appropriately. By the time you go home from the hospital, you can be eating, talking, appearing normal. So patients have to understand that, so they put themselves through the treatment and they get the best possible result.
So there was a lot of emphasis that you were giving on early treatment. So when we are talking about early as such, how early do you think they should actually immediately after the symptoms, like you said, the 2 weeks time, or what is it like? Because in India, especially,
Absolutely. So any of these,
in India, especially, majority
oh,
of
sorry, please
them
go ahead.
want to wait, and they do a lot of home remedies. Like, they think of it as it's because of heat. That's the commonest thing that I hear, at least in Karnataka,
Correct.
in many households. Whenever there's a pimple kind of thing on the tongue or anything of that sort, the first thing they say is mouth ulcers or anything. They say it's because of heat, and then they make them drink jeera water. All such remedies are given. So what is your take on this? What do you have to say on this?
No, you hit the nail on the head. That's absolutely accurate. Unfortunately, the understanding of this area, the head and neck, the mouth, is little poor because it's anatomically very complex. Even for doctors, it takes us a long time to understand what is going in each organ, lot of complexity, right? But the big problem that we have as oncologists is people don't think of oral cancer unless you spend 20 and 30 years smoking and drinking, right? There are two problems with that. Number one is, like you say, you think it's a pimple or it's heat or it's a dental infection, it's everything else, right? But the association is there for other cancers. If a woman has a breast lump, they will think of cancer and they'll get evaluated. If the patient has a lump in the abdomen, they'll think, oh, okay, it could be cancer. But for oral cancer, it's everything else until it's a big, huge wound, an ulcer, big swelling in the face. So 2 to 3 weeks is the cutoff, right? You lose nothing by getting an evaluation. It may not be cancer in a majority of patients, but just imagine that your cure rate in a stage 1 cancer is 85 to 90%, right? And if you are a stage 4 cancer, it comes down to about 50%. So a few months can cut your survival into half.
Okay. Okay.
So you just get evaluated by an oncologist, get identified. And the second thing, also, the problem with the smoking alcohol thing is that people don't realize, unfortunately, it's an addiction. Patients don't have control over it. So there's very little sympathy, compared to pediatric cancers and other cancers where people are more generous with donating time, money, things like that. There's a stigma associated with these cancers, especially when people use tobacco and alcohol. They don't want to admit it. I think we have to realize that addiction is a significant problem that we have to treat. It's not something that we judge and we shame. We have to treat it like any other disorder and disease, and we have to treat these patients well. We can't say that they brought it on themselves. It's their fault. Not every smoker and alcohol user gets oral cancer. So there are things that we don't understand. Our attitude towards this really has to change as a society.
One last question I have, doctor. What about post-surgery care? I mean, is it going to recur? Like, is it going to come back? What is it like?
So the big problem that we have with cancer is that some of these come back. Whatever we do, some of them come back, but the vast majority don't, right? And if we treat patients appropriately, which means that we stage them properly, we complete the treatment at one shot, vast majority of patients are cured. Another thing we have to remember is for people like me who treat a lot of this cancer, we are able to treat patients successfully even when it comes back. So we've gone beyond the point where we write off anybody with a recurrent cancer saying, I'm sorry, the disease has come back, there's nothing we can do. We are able to treat them with surgery and other modalities, radiation. So even those patients still go on to be cured. They have nice, meaningful lives. So we've really moved forward. So we have to get that out of our mind that if the disease comes back, it's a death sentence. Really not anymore.
Okay. Okay. Thank you so much, doctor, for your time. It was wonderful speaking to you. Thanks a lot.
Always a pleasure. Thank you.